All right, good morning. My name is Dr. Dale Bratzler. I'm the University Chief COVID Officer and the Enterprise Chief Quality Officer for OU Health. I wanted to start off with a couple of conversations about where we're at in the state right now with respect to the number of cases in Oklahoma. So as of today, we're just over 147,000 confirmed cases in Oklahoma. And right now we have somewhere around 24,091 active cases in the state. One thing I do want to highlight is that the active cases are the ones that we know about, but all researchers agree that there are far more people in the community probably infected that never got a test done or never went to a physician. So the number of people in the community that have an active infection is probably far higher, 4 to 5 times higher than that 24,000 number, which means your chance of encountering somebody in the community that's infected goes up substantially. In the past week, we've had 15,607 new cases. Deaths were down this week, 64 deaths this week. The 7-day rolling average of new cases in Oklahoma right now is 2230. So we're seeing more than 2,000 people being diagnosed every single day in Oklahoma. As I've pointed out before, there's substantial community spread of the virus, and particularly in rural communities right now in rural counties. So Oklahoma currently is seeing about 53.5 new cases per day per 100,000 population, but we have many counties in our state right now that are seeing more than 100 new cases per 100,000 population per day. And these are many of our rural counties around the state. So there is definite rural spread of COVID-19 right now. So far this week, the state has reported 83,000 tests that have been done, and of those 13.2% were positive so far this week, which is the highest percentage since I started tracking this at the beginning of the pandemic. Dr. Manter is going to talk about it a whole lot more, but as of yesterday, there were 1,279 people in the hospital in Oklahoma, 1,202 with a confirmed case, and 345, or almost a third of the patients in the hospital, were in an intensive care unit bed. When I send out a handout today that will highlight some of this data, I'm also going to highlight 2 studies that I want everybody to be aware of. The first was a fascinating, detailed study that came out of Stanford University, where they used cell phone records of 98 million people in multiple metropolitan areas. And they looked to see whether they could use the cell phone data to actually predict outbreaks that occurred in those metropolitan areas. And what they demonstrated was that their model worked very, very well, and that they were able to find what they called points of interest, places where people went that predicted higher rates of infection. So I'm quoting the article. It says, on average, across metropolitan areas, full-service restaurants, gyms, hotels, cafes, religious organizations, and limited service restaurants produced the largest predicted increases in the number of infections. That said, they also went on to point out that you don't need to completely shut down. You need to limit capacity at some of these places to substantially reduce the number of people who get infected. And then the second study was the largest study ever of what are the risk factors for potentially dying from COVID-19. It included more than 500,000 Medicare patients, and they showed that obviously advanced age, so if you're 85 or older, that doubles the risk of death, male sex higher, non-white race, and then the leading comorbid conditions, clinical conditions that a patient might have, included sickle cell disease, high risk, almost doubles your risk of death, chronic kidney disease, lymphoma or leukemia, certain cancers, heart failure, and of course diabetes, which is quite prevalent in Oklahoma. So those links will be in the handout that gets sent out.
Before we move on, when you were talking about restaurants, one thing that I've noticed is that a lot of people want to eat outside because they think, we've told them that it's safer outside, but now the restaurants realize that there seems like they're cramming a lot more tables close together outside. Is that still safer than going inside?
Yeah, so probably not. The Centers for Disease Control actually changed some of their recommendations around restaurants, and they've pointed out that you can see transmission both indoor seating and outdoor seating particularly if people are close together. So that while we generally think that outdoor activities are safer, there may be risk of transmission of COVID-19 in restaurants and outdoor seating, particularly if you're still close together. So my favorite is to go and get carry-out and take it to our home.
Dr. Mentor, if you will go ahead and introduce yourself, and then I will have a question for you.
I'm Dr. Cameron Mantor. I'm the Acting Chief Medical Officer of the OU Health Hospitals.
And just a reminder to repeat the question if you can. Medical professionals and hospitals have been advising for some time now that hospitals are strained and trends unsustainable. Yet we hear some conflicting data from other sources. How do you sort through and describe or explain the different stories about that?
So this question is about how do we manage patients? We're hearing that hospitals are full, we don't have ICU beds, but then we're also hearing that we can still manage to take care of patients in our hospitals. And so what I can tell you is that there's no question, the hospitals in our communities are strained. Our ICU beds are filling up, our med-surg beds are filling up, and it's both because of patients who are sick with the virus, but also all the other patients that we have to take care of with conditions that need health care. What I can tell you is that it's an hour-to-hour process. We're constantly managing patients who are admitted to the hospital, patients who are discharged from the hospital, those that need an ICU bed, those that don't. And so it's an hour-to-hour process. But at the same time, we are holding patients in other areas where we typically don't admit patients, such as an emergency room. So we may be holding 25 patients in our emergency room that are waiting for both med-surg beds and ICU beds. And so that's how we're able to continue to increase the number of patients that we can care for in our hospitals when we are at times saying that our ICU beds, for example, are full or our med-surg beds are full. We are just this week now have come up with we'll call it a regional distribution transfer center. So we are enacting a group that is going to help us, that can help determine for every hospital in the state what is their capacity, what's their capability, so that they can help direct patients to the facility that should best be able to take care of them. Those of smaller communities that can take care of patients who are less ill, providing time and space for quaternary hospitals like OU Health to be able to care for the sickest of our Oklahomans.
Can you just explain so everyone understands an ICU bed, a med-surg bed? What is the difference? What does that mean?
So we kind of think about three levels of care when you're an inpatient in the hospital. There's a typical med-surg bed, which is what we call them floor beds oftentimes. Patients are recovering from surgery. They are being treated for medical illnesses, whether it's infection or diabetes or heart disease. They need nursing care, but they don't need higher levels of medical care. That then transitions to a step-down bed where you have nurses taking care of fewer patients because their medical needs are more intensive. And then you have ICUs where you have critically ill patients who are oftentimes on ventilators, even ECMO machines, bypass machines to help with respiratory failure. And so there are graded levels of care, and each nurse in each area can take care of fewer patients as you work up through the system.
Okay. So you went into this a little bit, and that helped also, but if you maybe can explain a little bit more that where there's a situation where all the ICU beds in a city, county, or region can be full for a period of time, but hospital capacity could still be okay, or there could still be availability.
Right. So there are times when our med-surg beds and our ICU beds are full, but we're still able to care for patients. When this happens, we're typically holding them in an area that we see patients, like an emergency room, and we can take care of all levels of patients there, and they hold for a period of time such that we can find a bed for them either at our facility or perhaps at another facility in the community that may or may not have an ICU or a med-surg bed.
Okay. So we're going to go over to Dr. Bratzler. Dr. Bratzler, what is tell us about the testing availability right now. We're hearing that rapid tests and PCR tests are we're running out of tests, or maybe we're just running out of people that can administer them.
Yeah, so the question is about testing and what's the capacity right now. So I think many of the laboratories in the state still have unused capacity to do additional tests, but it does require medical personnel to either supervise the collection of the specimen or actually to collect the specimen. So I know our particular testing site that's done in conjunction with the Oklahoma City County Health Department has had an overwhelming number of new requests to get tests done because of the community spread of the virus right now. And in fact, they're limited. They've been doing about 400 tests a day. They're going to expand their capacity up to more than 600 tests a day, but we're getting requests for up to 1,300 a day. So people may have to go to several different places to get a test done. Right now, most of the tests that are being done in the state are PCR based, which is the most sensitive of the tests, but many urgent care centers and other places do have antigen tests that are available that are not as sensitive, but can give you a diagnosis. If they're positive, they're a very good test. So you may have to look around a little bit or wait a day or two to get a test done right now in some of the testing sites. The other challenge that I've talked about in the press has been the running out of the CARES Act funds that have been paying for many of the free tests in the state. And I know that some laboratories have been notifying us that they no longer have the capability to provide free testing because CARES Act funding is waning.
Should asymptomatic people be getting rapid tests or stick to PCR and quarantining? The FDA says rapid tests are not sensitive enough to detect a low viral load.
So the question is about if you're asymptomatic but you may have been exposed, you're concerned that you could have developed COVID-19 or you may have gotten it from, let's say, a roommate or a household contact. What test should you get? Should you get PCR or a rapid antigen test? And first let me say that there is no perfect test. You can have a false negative PCR test and you can have a false negative antigen test. A couple of things that we know, that if I was exposed to a person who had COVID-19 today, getting tested tomorrow with either test would largely be a waste of time because the likelihood that it would be positive is quite low because the virus hasn't built up enough to be detected by the test. So typically, if we're doing PCR testing, and the same will hold true of antigen testing, is that if you wait 5 to 7 days after exposure, the likelihood that the test will give you correct results is better because the person is more likely to have enough virus that can be detected by either of the tests. Antigen tests are not quite as sensitive, but again, if they're positive, they're very good. But if a person has symptoms, let's say somebody has cough, shortness of breath, fever, or any of the other myriad of symptoms that can predict COVID-19, and you get an antigen test, the rapid antigen test, and it comes back negative, those are the patients that we actually encourage to go ahead and subsequently do a PCR test, which is more sensitive.
Are there any symptoms of flu that are specific to flu, so you know if you have this would not be a symptom of COVID, or is COVID just can be anything?
So there's enormous overlap. The question is about the symptoms of both influenza and COVID-19. There's enormous overlap in the symptoms, and patients can present with symptoms of either illness and be difficult to tell the difference. There's only one symptom complex that appears to be unique to COVID-19, and that's loss of taste or smell. That typically does not happen with most viral infections or influenza. So if a young person comes in and they say, I can't smell anything or I can't taste anything, then until proven otherwise, we think they most likely have COVID-19 because those two symptoms are pretty unique to COVID-19. But everything else for the symptoms of influenza or COVID-19 overlap, and you can't tell the difference just based on symptoms.
Can you discuss the recent numbers in the state color levels in regards to schools? There's talks of Oklahoma County moving into a red level alert, and schools changing their course of action based on that. She was wanting to get more on what that means and what these recent numbers could mean to local schools.
So the question is about the map that many school districts use to actually make a decision about whether they go online or do in-person instruction. And right now, the Oklahoma School Boards Association produces a map. It's updated once a week, so it will be updated on their website today, that shows the amount of COVID-19 that's being diagnosed in the individual counties in the state. Many school boards have tied their decisions around online versus in-person teaching based on that particular map. I think I pointed out earlier that Oklahoma, the whole state right now, is seeing more than 53 new cases every day per 100,000 population, which means that there are going to be many, many counties in Oklahoma that now move from their orange 2 level to their red level. So I'm interested to see what the map shows today. I think there will be many more counties in Oklahoma that show up red on the School Board Association map, which may result in some schools moving to virtual education.
Can someone who has tested positive for antibodies or tested positive and recovered still transmit the virus?
So the question is about antibodies. If you have a positive antibody test, can you get COVID-19 or subsequently give COVID-19 to somebody else? And I think we've talked about this a lot. The antibody tests in general are not terribly reliable. There's 2 different ways to get an antibody test. Many physician offices or urgent care centers may use the finger prick where they stick your finger, use a drop of blood. Those tests aren't very accurate at all, and honestly, we don't put much stock in them. Or you can get blood drawn and do quantitative levels of antibodies in your blood. Those are done by many regional or reference laboratories. Many large hospitals have the capability to do that. Those tests are more reliable. However, as we've pointed out before, we don't know what to do with antibody tests. We don't know if it means just because you have positive antibodies that you have any immunity to COVID-19. Are the antibodies crossover from one of the other coronaviruses like the ones that cause the common cold? So right now we simply do not use antibody testing to drive any of the care that we actually deliver to patients. And I think just because you have a positive antibody test does not mean you're immune to COVID-19.
I have another question for Dr. Mantor. You're a part of a group of chief medical officers, right? And so this group just talks about how we're going to proceed and how we can have enough beds and just that kind of thing in general, I assume. So is there any kind of hope we can give the public, or just some kind of thoughts about where we're going with that as people are really and should be concerned about what it looks like in Oklahoma right now?
So the question is around the chief medical officers of all of the major hospitals in our community have been talking for months, since April, on a various number of topics. Everything from what do we think the best treatment for COVID-19 is? How should we best take care of our patients? I think what I'd like for the public to know is that all the chief medical officers, the infectious disease physicians, the epidemiologists, and the physicians like Dr. Bratzler, we're all communicating amongst ourselves, because this is not a OU health problem. It's not a different hospital problem. We're all facing the same problem. So we have been meeting regularly and talking about what can we do. So several things. How do we best take care of patients? What works well? Who needs to be in the hospital? Are there patients that can be cared for at home that we previously thought needed to be in the hospital but can be cared for at home? The other thing that we're trying to do is help figure out what can we do as hospitals? How can we create new beds? How do we take care of more patients? How can we safely do that? And at the same time, figure out where should patients best be taken care of? As I mentioned earlier, there are community hospitals that can certainly take care of the less acutely ill patients, and those that are quaternary type hospitals that take care of the sickest of the ICU patients, making sure that those are the places where we can get these patients that are most ill. And probably the other message that the CMOs are all 100% behind is trying to educate the public on what the virus does, how it's transmitted, but most importantly, what they have to do to help us curb the disease. You've heard both Dr. Bratzler and I talk about hospitals, doctors, nurses. We can't stop the pandemic. There's nothing that we can do that's going to stop the pandemic. It has to happen in the communities. And so the message that the CMO group would like for the public to understand is that we are all behind the idea that this is a respiratory virus, and the way to prevent its transmission is wearing a mask and social distancing and washing your hands. Medicines can help us treat patients when they're ill, but unless we can curb it, as we talked about months and months ago, blunt the curve, we are, as hospital systems, going to become overwhelmed at some point. Oftentimes get asked by the media, so when's that going to happen? And there's no way to predict, but unless we do something, if we continue to see the rise of positive patients and the need for hospital admissions that we've been seeing over the past number of weeks, we will be in a spot where we either can't take care of a COVID patient, or we can't take care of a patient with heart disease, or a level 1 trauma patient, or someone with a newly diagnosed cancer. That could be you, it could be your grandmother, it could be your child. We just don't know the answer to that. But we as a population who live in this state have to be part of the solution.
All right, I think, okay.
So I wanted to make one more point about COVID-19. I was having a discussion with some of my colleagues in public health yesterday, and we were talking about where we started with this in March. And remember when we were seeing exponential growth, we thought we were seeing a whole lot of cases of COVID-19. We were really scared. We didn't have the ability to test very much. We didn't have contact tracing. So we had to go to something called mitigation. Mitigation is where you apply broad brush approaches like everybody wear a mask, everybody wash your hands. We start shutting down certain things or restricting certain businesses or capacity, trying to reduce the spread because we didn't have the ability to do testing or contact tracing. We're back to that again. The other approach is called containment, where somebody tests positive, you identify them, you identify their direct contacts, you test everybody, you keep them either in isolation and quarantine. But we're now to more than 2,200 new cases every single day in the state of Oklahoma. We're starting to overwhelm contact tracing capability. We know that people aren't cooperating with contact tracing as well. So we're back to the point where we're having to start thinking about mitigation strategies, which again are these broad approaches to slowing the spread of the virus that include things like wearing a mask, and potentially, as the White House Task Force has recommended, limiting some capacity in restaurants, bars, and other things so that we slow the spread of the disease, because we can't keep up with it and we can't contain everybody right now.
So I just got two texts, both asking the same question. I guess Oklahoma City Public Schools just announced they're moving back to online learning, and Stillwater did as well. So maybe just expand a little more on the importance of schools moving back to virtual learning.
Yeah, so the question is about two school districts, Stillwater and Oklahoma City, I guess just announced that they're going to go back to virtual education. Very difficult decision, because we know that there are potential negative consequences for children not being in that social setting of school, and perhaps learning is better in that setting also. Balancing that with spread of the virus from students, between students, students to parents, students to grandparents. So it's a very, very difficult conversation. I'm not surprised, because as I mentioned, the state is seeing very large numbers of new cases per day by population, and Stillwater's been very high. Payne County's had very high rates of transmission of the virus. Oklahoma County still has the most new cases every day in the state of Oklahoma. I think there may be ways to consider different approaches down the road. For instance, we know that kids below the age of 10 don't get infected as often and may not be as big of spreaders as kids above the age of 10. But again, it's going to take time. This is brand new. None of us have done this before. I know the school districts, the school boards are very, very challenged to figure out what's best to do, balancing keeping people safe reducing spread of the virus with the benefits of being in the classroom for students. So I'm not surprised. I won't be surprised if we see it for more school districts. If we don't start slowing the spread of this virus in Oklahoma, I think we're going to have to go back to mitigation strategies where we do things like close down schools and go to virtual education, restrict certain businesses, whether we like it or not.
One more comment that just came to mind when you were talking about that. So when we're talking about mitigation strategies to help prevent the virus from getting to us, we have a number of months ago, we changed our visitation policy for both our children's hospital and our adult hospital. We allow 2 parents to come in to the children's hospital, 1 visitor in the adult hospital. I know that I believe Norman Hospital just changed their visitation policy and have removed the ability for their adult patients to have visitors. I can't imagine a 3-year-old having to be in the hospital and not having a parent with them is devastating for the patient, but also for the parents. And so we've tried to do everything we can to make it as safe as possible. But as this spread continues to go up in our community, all of the hospitals are having to revisit the possibility of removing visitors from the hospital. That is the last thing we want to do. We think that they help our patients in all kinds of ways, but it's a message that I think the public has to realize that we're having to discuss again because of the spread that is happening in the community. Again, it's the last thing we want to do. It's awful for the patient and for the families, but it is something that is becoming quite concerning again, and we're going to have to revisit that again.